Hello, I am Dr. Shirish Gadgil. I'm the Chief of Division of Hematology and Oncology at Henry Ford Cancer Institute in Detroit, Michigan. Today I'm going to be discussing when should I combine checkpoint inhibitors and chemotherapy in frontline treatment of advanced non-small cell lung cancer. Preclinical studies show that chemotherapy could enhance anti-tumor immunity. It can do so by inducing tumor cell death, which results in release of tumor neoantigens, which can be picked up by antigen-presenting cells, which in turn can prime and activate effector T cells. Chemotherapy could also reduce regulatory T cells. Based on these observations, several studies have been conducted evaluating the addition of immune checkpoint inhibitors to chemotherapy. In Keynote 189, pembrolizumab was combined with pemetrexed and platinum in metastatic non-squamous non-small cell lung cancer patients. In this randomized phase 3 study, addition of pembrolizumab to chemotherapy improved survival compared to patients who received placebo plus chemotherapy with a hazard ratio of 0.56. Similarly, in Keynote 407, addition of pembrolizumab to chemotherapy improved survival compared to placebo plus chemotherapy in metastatic squamous cell lung cancer patients with a hazard ratio of 0.64. In IMpower 150, metastatic non-squamous non-small cell lung cancer patients were randomized to carboplatin paclitaxel plus bevacizumab or carboplatin paclitaxel bevacizumab plus atezolizumab or carboplatin paclitaxel plus atezolizumab. In this trial, atezolizumab, when added to bevacizumab plus chemotherapy, improved survival compared to chemotherapy plus bevacizumab with a hazard ratio of 0.78. It is unclear if this four-drug combination necessarily provides better outcomes than the combination of pembrolizumab plus chemotherapy. At this year's ASCO, Dr. Martin Reck and colleagues presented the results of CheckMate 9LA. In this study, patients with stage 4 non-small cell lung cancer were randomized to chemotherapy or to nivolumab plus ipilimumab with 2 cycles of chemotherapy. Chemotherapy plus immunotherapy may provide faster responses and tumor shrinkage. Thus, pembrolizumab is the preferred option in patients with high tumor PD-L1. However, if the patient has high tumor burden, then in such patients, chemotherapy plus immunotherapy is the preferred option. Based on these data sets, the current treatment recommendations for the management of advanced non-small cell lung cancer are therapy is based on histology as well as PD-L1 expression and identification of genetic alterations. In patients who don't have targetable genetic alterations but have high PD-L1, pembrolizumab is the preferred option unless the patient has high tumor burden, in which case chemotherapy plus immunotherapy may be the preferred option. If the tumor PD-L1 expression is less than 150%, then chemotherapy plus immunotherapy would be the preferred option. Based on CheckMate 227, nivolumab plus ipilimumab could also be a consideration. Based on these data sets, the current treatment recommendations for advanced non-small cell lung cancer are testing of tumors for genetic alterations as well as PD-L1 and defining the histology. If the patient does not have targetable genetic alterations in their tumors, then patients are treated based on PD-L1 status. If the PD-L1 is high, patients are treated with single agent pembrolizumab unless the patient has high tumor burden, in which case chemo plus immunotherapy may be the preferred option. In patients whose tumor PD-L1 expression is less than 50%, in those patients, chemotherapy and immunotherapy combinations are the preferred options. In conclusion, combination of chemotherapy with immunotherapy is now standard of care for management of PD-L1 less than 50% advanced non-small cell lung cancer patients. Combination of chemotherapy with immunotherapy may be considered in patients with high PD-L1 if the patient has high tumor burden. Thank you for your attention.